silhouette or cardiac shadow on chest radiograph. That doesn't mean that it's all. So this is the scout image. When we do CT scan of the patient, CT chest, we put the patient in the scanner, and when we scout to see where things are first, and then we start scanning. So you can see the scout image. We have a very big heart here. It's more than 50% of cardiothoracic ratio. So this is big heart. And this could be just cardiomyopathy, dilated cardiomyopathy. All heart chambers are big, or it have pericardial effusion. Look at this CT scan. This is coronal reformatted image of this person. You see, this is my heart. The whole thing is the heart, and this is the fluid. So the patient has pericardial fluid. This is simple pericardial fluid on coronal image, and on sagittal reformat image. You see the fluid is here. When the patient in the CT scanner, they lie down. So the fluid, free fluid, will move to the posterior part of the pericardial cavity, here. So that's why it's piled up in the back. And this is on the axial. You see that? This is the heart, and this is the fluid. So seeing big heart on chest radiograph may be dilated cardiomyopathy, very bad valvular mitral valve disease, or maybe pericardial effusion. You don't know. You don't know just by the imaging. You probably know by the clinical context, but not by the imaging. Okay. So now today we're gonna talk about chest radiograph. The standard chest radiograph will be a PA or AP, and actually the original standard is the PA. Means that the beam is coming from the back, from the posterior to the front to the anterior chest. So this is how it looks like on the PA chest radiograph. We saw this yesterday. And look at our CT. When we do the scan, we scan the patient on axial images, and then we use the software to reconstruct those axial images into sagittal and coronal. So I'm showing you coronal reformatted images of the chest CT. Okay, so we'll start from the top. I'm going to stop it. So see that you start seeing something weird here on the top. When you go a little bit further, see that is the little air pocket, two air pocket. And then when you go a little bit further, this is the face of the patient. So this is the maxillary sinus. You are responsible for everything in the study. So this is the maxillary sinus. You start seeing mandible here, and then after that we start seeing the breast soft tissue. So this is a female patient, and it's a young patient, very dense breast soft tissue here. And then we go further, we start seeing bone. So this is my sternum. Normally we don't see sternum on chest radiograph, but we see it very clear on CT. And this is my sternum. This is xiphoid process. I'm going a little bit further. You see manubrium here. So it has, manubrium is right here. Okay, I'm gonna go further. And this is my clavicle. You see two clavicular head attached a little bit with the manubrium right there. That's forming cartilaginous joint here. And I'm going a little bit further. Okay, that is still my clavicle and ribs here. Look at the ribs. Yesterday I showed you one thing. I said that the ribs has two parts. The anterior part that is attaching to the sternum and manubrium, or the xiphoid process here. This is cartilage. Normally cartilage, we don't see it. It's really loosened. So on the chest radiograph, you don't see it until it has calcification in an elderly. You will see that. So this is the cartilage or anterior aspect of the ribs. Okay, I'm gonna go further. We start seeing a spine. So this is my thoracic spine here, and then this one is the spinous process. This little guy is the spinous process, and it's from the joint with the ribs in the posterior rib. So from the joint. Okay, so I think we are, and you see your scapula here, and your let me go, glenoid fossa, and then the humeral head. Right and left are the same. Okay, and you see all of these rotator, the scapular muscle, rotator cuff muscle here as well. Okay, so we're done with the soft tissue and the bone. Now we're gonna go further into the chest. We're gonna go see that the contrast we inject. This is CT chest with contrast. So you start seeing bright contrast in the vascular structures and the heart here. We injected the contrast from the right upper extremity, and the contrast coming through here. So it's going into the subclavian vein, and then the right there. Okay, this is the subclavian vein, and then this subclavian vein will join the right internal jugular vein. You see that this is the right internal jugular vein. Subclavian vein, it will become the brachiocephalic vein on the right. Pretty short. Okay, and then if you go a little bit further, so this is the brachiocephalic vein on the left. And the is coming from this brachiocephalic vein is coming from left internal jugular and left subclavian, and it's from the left brachiocephalic. Now left and right brachiocephalic vein is joining and then becomes a superior vena cava. This is superior vena cava, and this is entering the right atrium. This is my right atrium, and from right atrium, this is the tricuspid valve. It will go into the right ventricle. This is my right ventricle. That's why right ventricle is around here on the chest radiograph. From right ventricle, it will go into the pulmonary artery. This is my pulmonary artery. It's going up to the pulmonary artery. Name is artery, but actually is deoxygenated blood because it's accepting the blood from the head and from below. I will go to that later for the below. So this is the pulmonary artery. Pulmonary artery going out. This is main pulmonary artery. It divides into the right pulmonary artery and left pulmonary artery. So this part is the hilum. You can see this is my left hilum here on chest radiograph. It has pulmonary artery, a little pulmonary vein, and airways and lymphatic system that is forming the left hilum. The right hilum is the same way. Okay, so after that, going out and have gas exchange in the lung. After that, it becomes oxygenated blood and coming into the pulmonary vein. So this is my pulmonary vein is draining back into the left atrium. And this is your left atrium here. This is left atrium. And left atrium is going into left ventricle. This is my left ventricle. I'm going to show you a bit better here. So this is my left ventricle. This is my mitral valve. From left ventricle, it will go out into the left ventricular outflow tract. This is left ventricular outflow tract here, and this is the aortic valve, and this is the ascending aorta. So from the ascending aorta is feeding our body. So at the aortic arch, there are three branches. The first branch here is the right innominate. And right innominate will divide into the right common carotid, this one, and right subclavian artery, this one. Okay, that is the first branch. So the second branch is left common carotid, which is this guy. If you follow me, you can see left common carotid is going up here and very close to the thyroid gland, up here. This is my thyroid gland. This is the airway. We talk about the airways later. This is thyroid gland. That's normal thyroid. Normally, thyroid gland, the function is trapping iodine from food or from anything that's coming into the body. So this contrast media is iodinated contrast. So the thyroid gland will trap a lot of that contrast. So this is the left common carotid, which is the second branch from the aortic arch. And the last branch of the aortic arch is the left subclavian, this one. Okay, and if you'll see that it's curved a little bit, become left subclavian artery and go into the upper extremity. Okay, and let's look at the belly a little bit. So this is your liver. This person have a very well expanded liver. Normally, sometimes the liver, the left lobe stop here, right below the heart. Sometimes it's cross the midline and cover the spleen, like this one is covering the spleen. Okay, this is the portal vein in the liver. The liver has dual blood supply. This is the portal vein. This is the main and the left and the right portal vein. The liver looks good. And then you see, this is my descending aorta. Descending aorta coming down, supply the belly. Okay, this is my spleen right here. And this is the stomach with the fluid. And we also have a little bit of left kidney and right kidney. You can see it here. This is my right kidney and left kidney. And that is, we can't see those structure because it all blend together in the on chest radiograph. And I think we see, let me look at this. Okay, that is our chest radiograph compared to the CT. CT has way more detail than chest radiograph that you can see. Okay, that is frontal. And normally when we do sagittal, not sagittal, we call it lateral projection. So we it's a standard chest, so we have lateral projection as well. Okay, let's compare this structure. So this is reconstructed images on sagittal image compared to lateral chest radiograph from the beginning. Start seeing the humeral head and glenoid fossa from the shoulder joint, and then this is the scapula. This is the rotator cuff muscle, and you say a little lipoma. This is fat. Look at the fat density on CT, super dark. This is the fat in the muscle. There is a small lipoma. And we go further, you see a little bit of ribs, see scapula, spine here. Go further. This is on the right because we inject contrast. This is contrast in the venous system. So, and this is the liver. So we are going from the right to the left. And this is the breast soft tissue of the patient. And we see liver first. Liver looks nice and homogeneous looking. And let's look at the vascular structure again. So from lateral, this is the superior vena cava. Superior vena cava on chest radiograph is a little bit here, anterior to the trachea. And superior vena cava is draining into the right atrium. And then the inferior vena cava is here. You can see if I can make it. This is a column of the contrast. It's coming into the intrahepatic IVC, and then it is draining into the, see that? So this is draining into the right atrium as well. So it's from the top and from below. It's draining into the right atrium. From the right atrium, is passing through the tricuspid valve and going to the right ventricle. This is a right ventricle. Compared to chest radiograph, right ventricle will be right here, posterior to the lower sternum. And then this is from the right ventricle is going into the, this is the pulmonic valve somewhere around here. This is the main pulmonary artery. After that, become right and left main pulmonary artery, and then become after gas exchange coming back into the pulmonary vein. This is my left atrium. So left atrium has pulmonary vein drainage coming into it. Let me see. This is a pulmonary vein. Okay, let we see it better on axial. This is a pulmonary vein. It's draining into the left atrium. I'm showing you just branch of it. This is left atrium. Comparing left atrium on the chest radiograph, left atrium is here, around here, it's pushing the bronchus intermedius. This is the air column here, right here. So this is a left atrium. From the left atrium, it's going into the left ventricle. This is my left ventricle. Passing the mitral valve into the left ventricle. This is left ventricle. So the left ventricle shadow on chest radiograph is lower here. So the top of the posterior cardiac border will be left atrium. The bottom of the cardiac border on lateral projection will be the left ventricle. And from the left ventricle, we go into the aorta. This is the aorta. And this is the ascending aorta. compared to the chest radiograph, the aorta is here. And then curving up to the aortic arch. Aortic arch is here on chest radiograph. And on CT, aortic arch is here, and then descending aorta is coming down here. So descending aorta is here on top of the spine. And again, you can follow 3 branches of the aortic arch. This is a right innominate, and then left common carotid, and then left subclavian. So all 3 are here. For the belly, it's the same. So we see kidney on we see liver, we see the heart. So this is on the right. Sorry, on the left. On the left. So this is our kidney, and this is our spleen. Has different enhancement from the liver. And this is the right kidney because it's below the liver. Okay, and I think we are done with the sagittal and coronal CT. Now we're going to look at the raw data. We scan on axial, and we use axial images to do reconstruction. So you are seeing the thing that's already manipulated by the software. But this is the real raw data that we get at the beginning. But I don't have comparison to compare to, because the chest x-ray that we do, normally we do sagittal and sorry, we do PA and lateral. Okay, let's look at this on just normal anatomy here. So from the top, trachea, we will talk about airways later, but now let's focus on the soft tissue. This is the very dense, high density structure here close to the neck. So it is the thyroid gland here. Looks normal, very nice homogeneous enhancement. And then we going down. Let's do, as we talked earlier, we inject the contrast from the right, so the contrast is coming in, and then become the right subclavian, and from right subclavian it has the right internal jugular, and join that right subclavian, become the innominate. Sorry, I like to use that word, brachiocephalic on the right. So this is the brachiocephalic on the right. And then if you go down a little bit further, this one is the left brachiocephalic. And if you follow the left brachiocephalic back, you can see that it's from the left subclavian. Don't see a lot of contrast, but this is the left subclavian, and from the left internal jugular up here. So become the right and left brachiocephalic vein, become the proximal SVC, and then this is my SVC, this guy, and then SVC is draining into the right atrium. Okay, this is my right atrium. This thing is the right atrium. From the right atrium, this is the right atrium. Right atrium passing through the tricuspid valve, going to the right ventricle. You can see that how close the right ventricle to the sternum. After that is right ventricle. Right ventricle will go out to the lung, become the pulmonary artery. Oh, sorry. Okay. This is a pulmonary artery. Is coming out from the right ventricle, going to the pulmonary artery, become the right main pulmonary artery, and left main pulmonary artery here. And then after gas exchange, become oxygenated blood, will come back into the pulmonary vein. This is a pulmonary vein. Here is draining into the left atrium. This is the left atrium. See that how left relationship of the left atrium and the spine is very close to the spine. And then after that, left atrium passing through the mitral valve, going to the left ventricle. This is the left ventricle. From the left ventricle, it squeezes blood out to supply the body. So it's coming out. This is the left ventricular outflow tract. Going to the aorta, this is my aorta. After that, become the aortic arch, coming up here. This is the aortic arch. And then coming down, become the descending aorta. So we have all vessel complete. So this is the three branches of the aortic arch: right innominate, left common carotid, and left subclavian artery. So this is our brief anatomy of vascular anatomy of the lung here. And then you saw also we look for something else. So this person is a young person. The bone doesn't look so bad, and she has a very dense breast soft tissue. The left breast look a bit denser. I'm not sure why. If it is young patient, we probably leave it alone, because we don't do normally mammogram when we start doing for like a breast cancer. We start at 40 years old. She's for sure younger than 40 years old. And look at soft tissue, look at bone. I apologize, I don't have bone window for you, but let's look at the belly a little bit. This is my liver. The liver is so big, I mean, it's so long, not big, across the midline. The liver shape has a lot of variation. Sometimes it's so short, sometimes it's so long. So across the midline here, and even is wrapping around the spleen. See that? All this liver enhancement is different. This is the spleen, part of the spleen. The spleen was is wrapped by the liver. Okay, this is my portal vein. This is the portal vein. Okay, this is the IVC, intrahepatic IVC. If you follow me, look at this guy. It will drain into the right atrium. See that? See that? So SVC, IVC is draining into the right atrium. Okay, this is the spleen. This is the stomach. And then we still have, this is the pancreas. This is the pancreas. Yeah, very nice, juicy pancreas. And this is the gallbladder. See a little bit, don't see the whole thing. Still look okay. This is the kidney. So she has and she has a renal cyst here. And okay, look at the vascular again. So for the vascular, this is the abdominal aorta. This is the celiac trunk. Celiac trunk is supplying the liver and the spleen and the stomach. So this is my celiac trunk, and this is superior mesenteric artery. This is the splenic vein. Okay, all right, that is the raw data from the axial scan of CT anatomy. And let's do airways and fissure. So from that, I have a sagittal and coronal of the airways. So this is the lung window. You can see that it looks different from the one before. This is exactly the same patient, but I just changed the window from soft tissue window to lung window. So this is my right lung. Okay, don't mind that. Okay, this is my right lung. So we have the right upper lobe and right middle lobe and right lower lobe. See, there are two fissures on in the right lung. So this feature, this one is, we see it better. Let me show you here, and then we come back to that. So this is the right lung. Okay, let me stop this. So there are three lobes in the lung. This is the major fissure. This is the minor fissure. Okay, this is the upper lobe. This is the middle lobe, and the whole thing is the lower lobe here. Okay, sorry. And for this axial, for this coronal, there are three lobes. This is probably the best. One here, upper lobe, middle lobe, and lower lobe. Okay, and then for the lateral sagittal image of left lung. Left lung has two lobes. This is the fissure, long fissure. So the whole thing is the upper lobe, and this part below the fissure is the lower lobe. This is the where we talked yesterday about this. This is the posterior costophrenic sulcus. See how nice and sharp it looks. And this is lateral costophrenic sulcus, nice and sharp looking. So look at the airways. This is a trachea. In the midline, when it's coming down, it's bifurcate. So this we'll call this part carina. And then from that, this is the left main bronchus, very short. After that, it take off, become the right upper lobe bronchus. This is one. And then the rest of the airways become bronchus intermedius. From bronchus intermedius, it will divide into the lower lobe and middle lobe. This one is right middle lobe bronchus. And this one is the right lower lobe bronchus. So the left lung has a very long left main bronchus. From the left main bronchus, it will divide it into two lobes, left upper lobe bronchus and left lower lobe bronchus. All right, so we are done with the airways. We are done with the soft tissue. We have a little peek of the bone. So now we're going to look for this anatomy. I'm going to ask you, what is this structure? I'm going to point it out here. This structure right here, I show you on the CT. What is that? Okay, this is a normal chest radiograph, first thing first. Very good penetration, good exposure. So this is the tracheal air column. This is my left main bronchus. Can't see much of the left right main bronchus here. The structure that I am asking you is this little bump between tracheobronchial tree. This is trachea. This is the right upper lobe bronchus. It's sitting right here at the right tracheobronchial tree. Anyone know what structure is that? We always have a problem when we put the peripherally inserted central venous catheter, or here we call it PICC, P-I-C-C, in the patient. Sometimes the tip of the PICC is going toward, not going toward, to sit in that structure.
I think it's the tracheobronchial lymph node.
Okay, good thought. Okay, what else it can be? If you put things together, I'm saying that we always have the problem with the PICC placement, peripherally inserted central venous catheter. So when I say that it is in the venous structure, right? The lymph node is something outside the vein. It's in the soft tissue. So what else can be here?
SBC.
Superior vena cava.
Okay. So let me go back to anatomy again. Okay, let's look at this. So I'm talking about this structure right here at the tracheobronchial tree. Let's look. All right, do you see this structure? Let me stop it. I'm talking about this structure. This guy. That's a problem when people put the pig in. It's just plug in there, like just sit there. That structure that I'm talking about. Is it superior vena cava, you think? My superior vena cava is here. So this structure, we are talking about this structure, which is this guy. All right, so let me show you on lateral, on sagittal. You will be able to tell me if I show you the anatomy. Okay, so it is this structure. Okay, stop. This guy is draining into the superior vena cava.
Azygos vein.
What is azygos? That's good. See that? You don't have to tell you anything. You just have to look at anatomy. So it is the azygos vein. It's always sitting at the tracheobronchial tree. Sometimes it can look like maybe like you're right. Is if just by anatomy, it can be a lymph node easily. And when we put the PICC line, sometimes the PICC line we don't want it to go there. What we want is the tip is in the SVC or atriocaval junction, but sometimes it just got right in there somehow. And look at this. I'm talking about this guy, this little guy here, and also this one. See that? The filling defect in here is because of the flow artifact. It's not because of the thrombus. It's a flow artifact. This one is superior vena cava, And this one is about to be the right atrium. This is asparagus vein. Good. Okay, next one. Okay, what is this structure? I know it's just what you're talking about. It just look like aortic arch. So it's not aortic arch. It's something close to the aortic arch. See, normally, look at this again. Let me look back. Something, we see it here too. This is my, I'm not sure this is my aorta, a little bump here. I'm talking about a little bump. Okay, I'm talking about little bump close to the aortic arch. This little thing here, right there. Dimple, a little dimple here. So what structure is this?
Is this the pulmonary artery?
No, it is not. Pulmonary artery will be very big. If you look at this again, because we don't have problem to call pulmonary artery at all. Let me note that. Okay, pulmonary artery is here. It's lower. Let me stop. I'm talking about the structure that close to this person does not have it. It's not constant. You see it sometime, you don't see it sometime, but if you see it, it can be big, it can be small, depends on the patient has venous obstruction or not. So this is my pulmonary artery.
Left brachycephalic vein, I guess.
Okay, look at my choice. Did I say option here? This little guy, this guy. Okay. And do I have the next one? Do we know what structure is that? It's the venous structure. We're talking about that. And we're talking about this. See that? So it has a nickname. We call it aortic nipple. Have you heard about aortic nipple before?
I'm sorry, is it like the aortic knob, or like the arch of aorta?
Yes, it's closed. It's different structure. This is the aortic arch, but the aortic nipple is this little structure. Look at the CT here. Is the venous structure that is wrapping around the aorta, the aortic like a aortic arch here, and it will cause a little nipple adjacent to the aortic arch. I think
Intercostal vein, I guess.
huh?
Intercostal veins.
Intercostal vein. Posterior, I have option. So it is yes, intercostal vein. So this is the left superior intercostal vein. If you hear the name, people call it aortic nipple. So we are talking about the left superior intercostal vein, just in case that someone talk about the nipple. And when you look at chest radiograph, keep your eye, observe it. Sometimes you see it, sometimes it's so big, sometimes it's so small. So if the patient has venous obstruction, it will big because it's a path of the collateral circulation. But if the patient does not have obstruction, it may not be noticeable at all. Okay, so it's not it's the vein. Eventually it's draining into the SVC. Left superior intercostal vein, or the nickname is aortic nipple. Okay, what do we see on chest radiographs? Is this a normal chest? Does it look normal to you? The patient, suppose even gonna make things up here. The patient
No.
came just for annual checkup. Can he go home? Annual checkup, and then this is his chest radiograph.
No. No.
Why not? Is that you see pneumonia or you see something?
Edema type pulmonary.
Edema, pulmonary edema. Okay.
Very
Yes. What else? Is it lung mass, mediastinal mass, pneumonia, pulmonary edema, or
Yeah,
metastatic?
trachea shifts.
Yes, okay. Trachea is shifting a little bit, not right in the middle. But remember, we talked about this yesterday. The trachea can shift because we're getting older or you are a baby with different reasons. What else? Okay, let's go to do this together. Start from the heart. The heart looks okay to you? Or big heart?
No, no. It's very big.
It's very big. So we are seeing like a shadow coming down here, right?
Yeah.
Right. Okay, big heart. What else? Is it the pulmonary vasculature? Look like pulmonary edema yesterday? Look busy to you? The pulmonary vasculature will be very, very prominent in pulmonary edema. Is it noticeable here? If I said it's an annual checkup, means the patient does not have symptoms. So not likely to be pulmonary edema. Sometimes we can make a normal lung looks like pulmonary edema by adjusting the exposure on our workstation easily. Yeah. So no symptoms, so it's no pulmonary edema. Okay, big heart. Anything else? So trachea is shifting a little bit. Mediastinum looks okay to you? Okay, let's go back to the normal case. This is my near normal. Forget about this aortic nipple here. This is my near normal. This person is younger and memorize this chest radiograph. I'm gonna go to this case. Okay. Okay. All right. Okay. So now trachea is shifting and a big heart. Now we're going to look at this. I'm not going to tell you what it is. You can tell me after you see CT. Okay. Okay, so you said big heart, right? Does the heart look really big to you here? Look big or not? Looks normal or normal heart size or really big heart here?
Normal.
Normal. Yeah, you are seeing fat. See that? The whole thing is a fat. And if I stop it here, this is the fat. It fools you here. So the heart itself is not big. And actually, you can appreciate the heart border is right here. That is the left ventricular border. This is the pericardial fat. Okay, we are seeing fat. Okay, and the trachea is shifting. Let's look. So this is again anatomy, left ventricular outflow tract. This is the aorta. This is pulmonary artery. Okay, this is the aorta, pulmonary artery. Look at trachea. The trachea this is my trachea. It's shifting, actually. Look at this. This is shifting too. Why is it shifting? Does this look normal to you? Okay, this is my aorta. We just follow it up. And then the aorta is right here. Right here. Okay. Let me go back to the normal case. I'm sorry that I did not put them all in the same on the same image. Okay, look at my aorta here. This is my aorta, 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 and then aorta is coming down here, nice looking. All right, now I'm gonna go to the case. Okay, look at my aorta again. They look are they do they look alike? Okay, all right, let's come back here. This is the mediastinal mass. And this mediastinal mass is pushing the aorta to the left. And if you look at it again, this is aorta that was pushed to the left. And this is the thing that we think that is mediastinal mass. And actually, is it really mediastinal mass here? What structure is that? This guy.
Thymus.
Look at it again. I'm gonna follow it with me from the beginning. Okay, look at this guy. Okay, let's start from here. I'm gonna do here. Keep your eye on this structure. Okay, I'm gonna go. Keep your eyes on it. Keep your eye on it. Keep your eye on it. What is this structure? Okay, again, this guy, right, is the guy that is pushing the trachea, and then follow me. What structure is that?
Esophagus.
Esophagus is right here. This one is esophagus.
Thyroid tumor, I guess.
This one is aortic arch. The patient has right-sided aortic arch and has a lot of atherosclerotic disease. So it is losing elasticity and it's really hard. So the trachea is pushed to the left. See that? This is the mediastinal mass that turned out to be right-sided arch. Normally we don't have right-sided arch. We have left aortic arch, not right arch. But this person, the aortic arch is on the right, and then it's pushing the trachea away. It's look like mediastinal mass. Follow this guy. You can follow it to the heart. See that? It's coming down and connect here, up here, and then look at it. See that? It's coming up here, and then it's going right there, and then coming down. Normally, the aorta should be on this side of the spine, on the left, not on the right. So this is an example of the right-sided arch. Are we okay?
Yes.
Okay, all right, next one. I'm not telling you anything. We just have this chest radiograph and then the CT of the same patient. I have the patient information hidden here. Okay. So is chest radiograph normal?
No.
Not. It's not. Okay, let's do it one by one. The right lung for you looks okay. Is there any pneumonia, any focal lesion, any lung cancer, pneumothorax?
No.
No. Okay. So the right lung looks okay. Now what about the left lung?
Pneumothorax.
Okay. So pneumothorax, we have a case yesterday that we have pull line. This one I really can't see much. What I know is like the whole thing like opacity everywhere, and the trachea is shifting. And I cannot see the heart. I don't know where the heart is, maybe somewhere in here in the left lung, and then the trachea is shifting. So this tells me something. This tells me there is lung volume loss in the left. So it is pulling everything to it. What lung volume loss, either prior surgery, maybe lobectomy or pneumonectomy, or the patient has like a mucoimpaction of the entire left main bronchus and then caused obstructive atelectasis and lung volume loss, and then those atelectasis pulling the heart, pulling the left, pulling the trachea toward the left. So that's what I can guess from here. There's still some lucency in the left lung. I'm not sure, is there air in the left lung or is there air in the right lung that's caused the midline and try to replace that. Okay, so there's something wrong. So from this, we're gonna say there are evidences of lung volume loss, severe lung volume loss on the left. But what's going on in there, we don't know. It could be a mass, it could be pneumonia combination with pneumonia, it could be pneumonectomy, I don't know. Okay, this is our CT. This is our right lung. You see how it's very well expand toward the midline, cross the midline, and then going to supply part of the left lung. And we don't even see left lung here. It's all gone. And the heart is here. So the heart, aorta, and great vessel is all in the left lung. What's happening? So this is like look at this. This is my midline, and the right lung is crossing across the it crosses midline and then to the left. And then this is my aorta. This is the heart shadow. Okay, and we don't see left lung. Okay, let's look at the airways. This is our trachea. This is our carina, and we're gonna focus on the left lung. It's gone. The left main bronchus cut off, and everything is gone. One of you asked about esophagus. This one is the air in the esophagus here. It's not in the trachea. Trachea is this one, but this is the air in the esophagus. So this is an example of pneumonectomy. So after we did pneumonectomy, eventually the whole thing will be gone. There's no more left lung, and you can see the bronchial stump because here, stump here, see that? And then it's cut off. So this is an example of pneumonectomy, just post-op and the usual post-op left pneumonectomy. Okay, I'm going to show you a few more cases and then we'll stop. Okay. This one I showed you yesterday. We have this case yesterday, but I did not show you the CT. So we see a big mass in the right upper lobe and coming down to the hilum, above the hilum here, and this here big huge mass in the right upper lobe. Okay, let's look at this on CT. This is how it looks like. Very heterogeneous enhancement, big mass. I have only one shot here on coronal, and then on axial, see, very big mass. Not the whole thing is the mass. Most part are big mass, but some parts are obstructive changes from the mass that has pressure effect from the air to the airways. And this is how it looks on the CT. This is a big right upper lobe mass, and this is the superior vena cava. It was pushed. This person can have SVC obstruction easily, but at the moment, there's no SVC obstruction yet. It's still patent. So this is lung cancer. Adenocarcinoma, this is a lung cancer. All right. That one I showed you because we have it yesterday. Okay, what about this one? PA, is this normal? Look symmetric. Everything looks perfect here. There's nothing there. Okay. What about lateral? If anyone pick up anything, I think this one may be a little bit too difficult because it's really subtle. On the PA, it look perfect, look normal, but the lateral is not. There is a soft tissue density right here above the diaphragm. So that is kind of soft tissue density, which we don't see is on the PA. If I were to read this case, and I don't have prior study and I know nothing about the patient, I will say, I see something here. I don't know what it is. If the patient comes in with fever, with cough, this may be pneumonia. If the patient does not have symptom and he's old and he's a smoker, that may be cancer, which I cannot appreciate that on the PA. I'm going to suggest to do a CT. If this person have infectious symptom at the beginning, I will say likely pneumonia. Treat the patient, come back and repeat chest radiograph. I would say that. But if the patient is old, I'm going to ask for CT. See, the decision making is different to the clinical context. So one of my senior colleagues used to ask residents, what are the three most important things that you need to do when you do chest radiograph? He always say, patient history, prior study, patient history, prior study, patient history, and prior study. That's all his answer. So all three things that he's saying is just patient history and prior study. So those are very important. In the United States, you don't get you don't get an accurate clinical history. It's just bad. You have to dig it by your own and assume what are you looking for sometime. So in conclusion, this person has a soft tissue density in the retrocardiac region. We see it on lateral projection. We don't see it here. So it is this structure. You can tell me what it is. Okay, I'm going to show you lateral. Is this structure? What is that?
The
Descending,
stomach.
descending
Yes.
thoracic aorta.
This is this aorta. Don't forget we have this is contrast enhancement. So the vascular structure has will have the bright density. This structure is outside the aorta and is one of us say it's a stomach. Yes, it is.
Esophagus.
Yes, it is the hiatal hernia, so it's not esophagus. So this one is a big sliding hernia. So the EG junction is above the diaphragm, and then the stomach is up above the diaphragm. This is the stomach rugi. So the whole thing is the stomach. So this is an example of hiatal hernia that you can see. Oh, it's always sit here. Sometimes it's so big and it's covering the spine. So this is the same person, and the study was done not so long apart. Sometimes you see it, sometimes you don't see it. Depends on it's sliding at the time when we do the chest radiograph or not. So it will not be there all the time unless it's really really big. The small one can move up and down, but the big one it will always there. Like this one is pretty big. This one is an example of hiatal hernia, and good that you pick up the stomach rugi. This is the stomach. Yes. Okay, next one. Oh, I am sorry. This one is very subtle. We're not going to see anything on chest radiograph. If there is a little opacity here in the left upper lobe here, which on CT is look bad, right? So this is a lung window coronal reformat image of CT scan. This person has a lobulated, spiculated right upper lobe mass here, maybe about like 3 centimeter by 3 centimeter. This background, there is little holes in the lung here, so the patient is a smoker. So this is an example of lung cancer, and I want to show you how many we miss on chest radiograph. I don't know about this case that we missed this or not, but I haven't looked at the history, but I'm going to show you how subtle lung cancer can be. Just that, and become this bad looking on CT. This is a left upper lobe adenocarcinoma. Okay, so for the smoker, if we see something that we are really not sure, we always ask for CT because we have no idea. It can be lung cancer easily, and we miss a lot on chest radiograph. That's why in the United States we have lung cancer screening program for the smoker. Okay, this is a young person with fever.
I think it's a lobular consolidation, like pneumonia, maybe.
Okay, where exactly it is, you think?
I
I
think
show
it's the right upper lobe.
right upper lobe. Okay, all right. So we can see this feature. This is the minor feature. So below the minor feature is a right middle lobe. So is it the right upper lobe or the right middle lobe, you think? Or both?
Oh, now I'm not sure at all.
Okay, look at lateral, where it may help. It may help. Okay, I forgot to tell you. So when we do chest radiograph here, we will have two more post-processing image. This is the routine lung air that we normally see. We will see subtraction, that we will subtract the bones out. And another subtraction that we will subtract the lung out, see only bone. So we will, one shot of the study, we process two more images. So we will get 3 images from one shot. And then this is her lateral, his lateral chest radiograph. So we are seeing here, this is our fissure, our minor fissure, and this is the thing. The whole thing has the opacity or consolidation. So I'm fooling you because the extension of the upper lobe itself is not just that. Because on lateral, you can see that how far it can go. So this is on CT. See that? So this is my fissure. This is my fissure. And on CT lateral, this is my fissure. So the whole thing is is in the right upper lobe. You are right at the beginning, but because when we do chest radiograph, the beam is coming from the front. So that's why you are seeing part of the inferior part of the right upper lobe that is overlapping with the right middle lobe. Okay, you're correct at the beginning. And normally pneumonia, the usual pneumonia, we call it lobar pneumonia. So it will confine to one lobe only. It will not cross the fissure and go to the next lobe because there's no connection. Fissure is a national barrier between lobes. Once you get trouble in one lobe, it will stop. It's almost like a big block, a big barrier between two lobes. So the infection will not cross that fissure. That is in general. I'm talking about the lobar pneumonia. Sometimes if you have aspiration or bronchopneumonia, it will cross the fissure. And that is an exception as well. If the fissure is complete fissure, the whole thing is separate. Upper and middle lobe is separate. It will prevent the infection spreading. But if the fissure is incomplete, the infection will cross that fissure and go to the right middle lobe. So it depends on the national barrier of that person. It has complete fissure or incomplete fissure. So this one, an example of a young person. This is a right upper lobe pneumonia. And if I were to read this case from this, and suppose this is 25 years old person, his bone doesn't look so bad, so he's young. So I will say, okay, I'm thinking this is the right upper lobe pneumonia, and I will stop. I just say that, okay, go back, treat the patient with antibiotics. And if the symptom is getting better, you do nothing else. Done. If the symptom is still there after you expect the patient to get better, or the patient is getting worse during the symptom, come back and do CT. If this is an 65 years old man and is a smoker, I would say, I'm not sure this is pneumonia or this is lung cancer and hiding in the pneumonia because they can coexist. So in an elderly, I would say, okay, I see here is likely pneumonia. Suppose 65 years old come in with no symptoms at all. This is definitely cancer. 65 years old smoker come in with symptoms. This can be pneumonia, can be cancer. So in that case, I would say, go back to the patient and come back to chest radiograph again. If the chest radiograph is better, I'm not satisfied. He has to come back until it's gone. And if chest radiograph after the treatment, symptom is getting better, but the chest radiograph look bad, still look really bad or look even worse, I will ask to do CT. See, our decision and recommendation is based on the clinical context. Always different age group, different management, and different recommendation. Okay, this is the right upper lobe lobar pneumonia. Okay, I think this is the last one for today. What do we see? This person is pretty sick. This is the ET ET tube, and this is the NG tube. We don't see the whole thing, but this is the NG tube and ET tube. ET tube looks good because this is the carina, and this is the right upper lobe bronchus, bronchus intermedius, left main bronchus. Don't mind, there's some like bibasilar, retrocardiac atelectasis, and a little bit effusion. What else do we see? The heart looks big or not? The heart looks okay, not big. Okay, we're not going to pay attention to the heart. The lung, we already talked about it. Pleural effusion, we already talked about it. Now we talk about mediastinum. Looks normal to you?
I think I can see a really big, maybe a mass on the upper side of the, like in the center.
Yes. So there is a big mass. When the mass is big, we have no idea where it's coming from. When the mass is the medium size, that's the best way, that's the best time to tell where the mass coming from. This one, I have no idea. If we don't see the patient, we just say, oh, big, either mass in the neck itself, like soft tissue outside, or a mass in the mediastinum, because it's just so big now, we cannot tell. Okay, let's look at the CT. The vessel is displaced. This is my ET tube is here. So there's a big heterogeneously enhanced necrotic mass, superior mediastinal mass. I did not do the movie for you, did not get the movie in, but this is a thyroid cancer. Thyroid cancer does not have to be a big mass. It can be smaller than this, but produce a lot of symptom and abnormal thyroid function test. So the thing is, when you see trachea deviation, don't forget to think about the thyroid mass as well. That the upper trachea, and this one is a big mass. It's not deviate a lot, like see here. Still, this is the spinous process. See that? Normally, this tracheal air column should be right in the middle. So it's pushed away tracheal air column to the right. So it is a big mass extrinsic pressure effect to the trachea here. So an example of thyroid mass and thyroid cancer. I think that's it for today. I am on time, 1 hour. Do you have any